Imagine going to the eye doctor because you're slowly losing your peripheral vision. Like you feel like you're navigating the world looking through this narrowing tunnel.
Right, which is terrifying.
Yeah, exactly. And you just assume you need a new prescription or something, only to find out the real culprit isn't your eyes at all. It's actually this tiny tumor sitting at the base of your brain, and it's causing your body to, well, basically chemically prepare for a pregnancy that doesn't exist.
It's a completely shocking diagnosis for people.
It really is. So, welcome to our deep dive into the source material. Today, we are exploring a pretty huge stack of medical guidelines, clinical histories, and endocrinology reports from MD Anderson, the Endocrine Society, and the Cleveland Clinic.
There's a lot of data to get through.
There is. And our mission today is to untangle this deeply fascinating condition called hyperprolactinemia and its most notorious driver, which is the prolactinoma.
Yeah, the prolactin-secreting tumor.
Okay, let's unpack this. We usually conceptualize your body as having this master control room, right? The pituitary gland.
Right, the master gland.
Yeah, perfectly tucked away at the base of the skull in this protective little bony cave called the sella turcica.
Which literally means Turkish saddle, by the way.
Oh, I didn't know
Yeah.
that. That's fun. But yeah, it usually flawlessly directs the metabolic symphony of your entire body. But we want to look at what happens when just one specific button inside that control room gets totally jammed.
And it causes a profound systemic short circuit, honestly. When this specific button gets stuck, when the highly specialized cells responsible for prolactin production just lose their regulatory input, they flood the bloodstream.
Just massive amounts of prolactin.
Exactly. And you end up with the highly specific cascading disruptions. We're talking about things that affect everything from crashing your sex hormones to severe bone density loss,
Wow.
and even, like you mentioned, structural compression of the optic nerves. It really highlights how precarious our baseline endocrine balance actually is.
So before we get to the system crashing part, let's establish that baseline for everyone, because we need to know why we have this hormone in the first place, right?
Right, abnormal physiological force.
Yeah. So prolactin is synthesized by these things called lactotroph cells in the anterior pituitary gland. And its primary famous job is stimulating breast milk production during pregnancy and lactation.
Right.
So obviously, in a non-pregnant, non-lactating person, baseline serum levels need to be kept incredibly low. I think the clinical sources put the normal threshold at less than 25 nanograms per milliliter for women and under 17 for men.
Precisely. It's a very tight window. And to maintain that tightly controlled baseline, the brain relies on a constant active inhibitory signal.
The brake pedal.
Exactly, the brake pedal. And that signal is dopamine. It flows down this pathway, the tuberoinfundibular pathway, directly from the hypothalamus to the pituitary gland.
Okay, so reading through the physiology in our sources, it actually sounds less like a brake pedal and much more like a dead man's switch on a train.
Oh, that's a good way to look at it.
Like, dopamine is the hand physically holding the lever down at all times. If that hand slips off the lever for literally any reason, the lactotrophs just immediately trigger the alarm and dump prolactin into the blood.
That is a much more accurate visualization, yeah, because the default state of a lactotroph cell is to secrete.
Wait, it wants to secrete all the time.
Yes, it structurally wants to release prolactin continuously. Dopamine is literally the only chemical preventing it from doing so.
Yeah.
And, what's fascinating here is how easily that dead man switch can be temporarily released by really mundane, acute physiological stressors.
Right. The clinical guidelines noted these transient spikes from things like intense exercise or just sleeping or eating a high-protein meal.
Or even the anxiety of a blood draw, yeah.
Yeah, venipuncture. But let me push back on this a bit. If the system is so highly sensitive that just getting a needle in your arm doubles your prolactin, why isn't your body constantly thrown into endocrine chaos every time you get, stressed in traffic?
That's a great question. It comes down to the hormone's half-life and the efficiency of the feedback loop. Prolactin has a serum half-life of only about 20 to 50 minutes.
Oh, so it clears out really fast.
Very fast. When you experience an acute stressor, central dopamine tone drops momentarily and prolactin spikes. But as soon as that stressor passes, dopamine floods right back down the pathway, pushes that lever back down.
And the excess prolactin is just cleared from the blood.
Exactly. The transient spikes simply do not last long enough to downstream suppress the other hormonal axis.
Okay, I see. So the true clinical danger is when the hand is permanently removed from the liver.
Exactly. When we look at chronic hyperprolactinemia, we have to look for what is structurally or, chemically blocking that dopamine pathway long term.
And the first suspect in modern clinical practice is often pharmacology, right? The medication-induced
That's
cases.
very common.
Because it's wild that treating a totally unrelated issue can cause this. The sources list antipsychotics like risperidone and haloperidol, SSRIs for depression, anti-nausea drugs like metoclopramide.
Even certain heartburn medications.
Yeah, proton pump inhibitors. And they work by blocking dopamine receptors. But wait, if dopamine is the universal dead man switch, and tens of millions of people are walking around taking SSRIs or acid reflux meds every single day.
Why isn't everyone lactating?
Exactly. Why isn't half the population walking around with chronically elevated prolactin? Does the pituitary just adapt to the meds eventually?
Well, no, the answer really lies in receptor affinity and the blood-brain barrier.
Okay.
So the medications you mentioned, they don't all bind to dopamine receptors with the same strength. Risperidone, for example, has an extremely high affinity for the D2 receptors, specifically located on those lactotroph cells.
Ah, so it targets them directly?
Right. And furthermore, it doesn't cross the blood-brain barrier efficiently, so it concentrates in the pituitary, which actually sits outside the blood-brain barrier.
Oh, wow, I didn't realize that.
Yeah, so that causes a profound sustained blockade.
So it aggressively knocks the hand off the lever, basically.
Yes. But conversely, other drugs, like certain SSRIs, have a much weaker secondary effect on overall dopamine tone. So they might bump a patient's prolactin up to, say, 30 or 40 nanograms per milliliter.
Which is high, but not crazy high.
Right, not high enough to cross the threshold that causes severe, noticeable clinical symptoms in everyone. Medication-induced cases generally hover between 25 and 100.
Okay, that makes perfect sense. It's about how hard the specific drug hits that receptor. But here's where it gets really interesting. If a patient is not pregnant, and they aren't on any of these high-affinity medications, but their prolactin levels are sitting at like 200 or 500.
Then the clinical guidelines point squarely at a structural issue. A tumor.
A prolactinoma?
Yes, it's a monoclonal proliferation of those lactotroph cells. Basically, a single cell mutates, escapes the dopamine regulation entirely, and just begins cloning itself.
Just going rogue.
Completely rogue, forming a benign adenoma in the pituitary gland. And they are common. Prolactinomas account for up to 40 to 60% of all pituitary tumors.
And the sources categorize them strictly by their anatomical size, right? Like microdenomas are under 10 millimeters. Or 1 centimeter. Macrodenomas are over 10 millimeters.
That's right.
And that somewhat arbitrary cutoff actually dictates the entire clinical history of the patient, doesn't it?
It entirely dictates the presentation, largely because of how the excess prolactin interacts with the rest of the endocrine system.
So what's the actual mechanism there?
Well, the primary downstream target of chronic hyperprolactinemia is gonadotropin-releasing hormone, or GnRH.
Right, because high prolactin fundamentally suppresses the pulsatile release of GnRH from the hypothalamus.
Exactly.
And since GnRH is the precursor that triggers your other sex hormones, the whole reproductive axis just shuts down. Estrogen plummets, testosterone plummets.
And that biological cascade creates a stark divergence in how men and women present clinically.
Yeah, I really wanted to talk about this.
For premenopausal women, the plunge in estrogen, coupled with high prolactin, causes immediate, highly visible disruptions. Amenorrhea, which is missed periods, and galactorrhea milky discharge are the classic hallmarks.
Also vaginal dryness and infertility, right?
Yes, absolutely.
The clinical histories we reviewed showed that because these symptoms are so overt and honestly disruptive to daily life, women are almost always diagnosed quite early.
Right.
They go to their physician, the labs are drawn, and the tumor is caught while it's still a tiny microdenoma, maybe just 3 or 4 millimeters in size.
Usually, yes. But the clinical history for a male patient is completely different.
Why is that?
Well, men don't have the same overt physiological alarms. The suppression of GnRH leads to secondary hypogonadism, which just means chronically low testosterone.
Right.
So the clinical symptoms are just a gradual decline in libido, erectile dysfunction, lethargy, maybe a loss of muscle mass over time.
Which, unfortunately, are incredibly nonspecific. I mean, a guy in his 40s or 50s experiencing low energy and low libido might just write it off as stress or depression or just aging.
Exactly. He might even go to a clinic and just get put on testosterone replacement therapy without anyone ever checking his pituitary function.
Oh, wow. So the root cause goes completely undetected.
For years, sometimes. And because those lactotroph cells continue to multiply unchecked by dopamine, men are overwhelmingly diagnosed much later with macrodenomas.
So the tumor has had years to grow past that 10 millimeter mark.
Yes.
And since it's trapped in that tiny bony cave, the cella turcica, it only has one anatomical path of least resistance, which is up, right out of vault.
Yes, it expands suprasellar upward and physically compresses the optic chiasm, which sits directly above the pituitary gland.
Okay, this is the mass effect and the visual loss I mentioned at the very beginning of the show. The optic nerves cross right at that spot. So when this giant macroadenoma pushes up against the underside of the chiasm, it specifically damages the nerve fibers carrying information from the peripheral visual field, right?
Exactly. The patient develops bitemporal hemianopsia.
Bitemporal hemianopsia.
Yes, literally losing the outer halves of their vision in both eyes. And it's an insidious mass effect. A patient might not even notice it until they start bumping into door frames or sideswiping cars.
Because their brain just compensates for the tunnel vision. That is terrifying.
It is. But if we connect this to the bigger picture, regardless of whether a patient comes in early with a microadenoma or late with a visual deficit from a macroadenoma, there is a silent threat that mandates treatment for everyone.
Even if the patient is like, I don't care about the low libido, just leave it alone.
All right, doctors won't just leave it alone.
Why not?
Because of the skeletal system. Estrogen and testosterone are absolutely critical for maintaining the balance between osteoclasts and osteoblasts, the cells that continuously break down and build up your bone matrix.
Oh, I see. So chronic sex hormone suppression means chronic bone resorption outpaces bone creation.
Precisely. Long-term hyperprolactinemia leads directly to osteopenia and severe osteoporosis.
Wow.
The skeleton essentially hollows out over time, leaving even asymptomatic patients at a massive risk for debilitating fragility fractures. So treatment is mandatory to preserve bone architecture.
That makes total sense. So, okay, if a patient presents with unexplained low testosterone or those visual field deficits, how do doctors actually crack the case and confirm it's the pituitary?
Well, they order a serum prolactin test.
Obviously. But you mentioned earlier that the system is incredibly volatile. Like, prolactin has a short half-life. It spikes when you sleep. It spikes when you're stressed.
Very volatile, yes.
So if I wake up, chug a coffee, sit in rush hour traffic, and get a needle jabbed in my arm by a phlebotomist, my prolactin is going to be wildly inaccurate, right? Wouldn't a morning test be a huge false alarm?
You are highlighting a massive pre-analytical challenge in endocrinology right there. The Endocrine Society guidelines explicitly warn against taking a sample right after waking,
Okay.
because the sleep-induced hormonal surge hasn't cleared the system yet. The absolute gold standard protocol requires a fasting blood draw taken in the mid-morning.
Mid-morning, got it.
Yeah.
But what about patients who just have severe needle anxiety? The venipuncture itself is an acute stressor, lifting that dopamine bedman switch right as the blood is being drawn.
Yeah, that happens. To circumvent that, specialized endocrine clinics use a cannulated resting protocol.
What is that?
They insert an IV cannula, leave the patient alone in a quiet, dimly lit room for 30 to 60 minutes to let the autonomic nervous system completely settle, and then draw the blood seamlessly from the line without a second needle stick.
Oh, wow. That level of precaution shows just how exquisitely sensitive this hormone really is.
It really does.
But even with perfect technique, the laboratory can still get it completely wrong, right? The clinical sources detailed this macroprolactin phenomenon, and I just found this so fascinating.
Oh, the macroprolactin fake-out, yes.
Yeah. You can have a patient with zero symptoms, perfectly normal MRI, normal reproductive function, but their lab results show sky-high prolactin levels as if they have a massive tumor. How does a state-of-the-art lab machine get fooled that easily?
It comes down to the specific mechanics of the immunoassay. Standard lab tests use specialized antibodies to detect and count prolactin molecules.
Right.
They are designed to recognize the chemical signature of prolactin. But in some patients, individual prolactin molecules bind together with circulating immunoglobulins, specifically IgG antibodies, to form a massive clustered aggregate.
Like a big clump.
Yes, a big clump. This is macroprolactin.
So it's basically a giant clump of prolactin bound up by the patient's own immune system. But why doesn't that clump cause symptoms?
Because of its immense molecular weight. Monomeric prolactin, the normal kind, is small enough to easily exit the capillaries and bind to tissue receptors. Macroprolactin is so bulky that it is physically confined to the vascular space.
Yeah. So it can't cross over to reach the receptors.
Exactly. It's biologically inert. It's harmless.
But the immunoassay machine doesn't weigh the molecules, right? It just scans the serum for the chemical signature.
That's the problem. The immunoassay's antibodies grab onto the macroprolactin clump, recognize the prolactin trapped within it, and count it as active hormone, triggering a massive false positive.
So to avoid misdiagnosing a perfectly healthy person with a brain tumor, labs have to manually, what, filter it out?
Basically, they have to precipitate the sample. They add a chemical like polyethylene glycol to physically force the heavy macroprolactin clumps to drop out of the serum, and then they measure whatever true active prolactin is left floating at the top.
That is so cool. And it's a mandatory screening step now, right? For asymptomatic patients with elevated readings.
Yes, absolutely mandatory before panicking. Once macroprolactin is ruled out and pharmacology and thyroid issues are cleared, the definitive diagnostic step is anatomical.
Imaging. The MRI with gadolinium contrast.
Yes, and the contrast agent is crucial here. Normal pituitary tissue and adenoma tissue absorb the contrast at different rates.
Okay.
So on a dynamic MRI, the normal gland enhances brightly and quickly while the tumor remains darker. This allows the radiologist to precisely map its borders, its exact size, and its proximity to the optic chiasm.
Okay, so let's say the MRI is done. The radiologist spots a 15-millimeter macroadenoma pushing directly against the optic nerves. You are sitting in the neurologist's office, you are literally losing your vision, and they tell you there's a tumor in your skull.
It's a heavy moment.
Yeah. The immediate assumption is that you're going to be prepped for invasive brain surgery, right?
You would think so.
Right. But the clinical consensus for prolactinomas completely flips the script on how we treat solid tumors. How invasive is the surgery for this usually?
Well, here is one of the most remarkable facts in endocrinology. Surgery is rarely the first option. No scalpel required for most patients.
Which sounds completely counterintuitive when a physical mass is actively crushing a cranial nerve. How do you resolve a structural mass without a scalpel?
By exploiting the tumor's fundamental biological vulnerability. Remember that these rogue cells are still lactotrophs.
Okay.
They still possess functional D2 dopamine receptors on their cell membranes. So instead of cutting the tumor out, endocrinologists simply prescribe potent dopamine agonist medications, primarily drugs like cabergoline or bromocriptine.
Oh, so these drugs act as a highly concentrated synthetic version of the dead man's switch.
Exactly. Cabergoline has an exceptionally high affinity for those D2 receptors. When it binds, it doesn't just inhibit the secretion of prolactin, it triggers intracellular pathways that actively halt DNA synthesis and induce apoptosis.
Programmed cell death.
Yes, within the tumor tissue itself.
So the medication literally causes the tumor to self-destruct and just kind of melt away.
It's incredible to see.
The case studies in the sources were astonishing. I mean, there are serial MRIs showing a massive tumor completely obliterating the cella turcica, and then 12 months after starting oral cabergoline therapy, it's just gone.
Just a tiny remnant left.
Yeah, it shrinks down to a tiny, clinically insignificant remnant. Vision is restored, the optic chiasm is decompressed, and the reproductive axis completely reboots.
It is medical magic for most. Upwards of 90% of patients achieve normalized prolactin levels and significant lasting tumor shrinkage just by taking a pill once or twice a week.
It's amazing. But, I mean, if the pill works 90% of the time, I have to ask about the outliers. What if the dopamine agonist just doesn't work, or the patient has horrific side effects from the medication?
This raises an important question. What do we do for the 10% who are resistant? In cases of true biochemical resistance, or if there is a sudden catastrophic hemorrhage into the tumor.
Wait, it can bleed?
Yes, a medical emergency known as pituitary apoplexy, which causes sudden blindness and an excruciating headache. If that happens, then surgical resection is absolutely required.
But even then, the anatomical approach is fascinating. They don't perform a traditional craniotomy, right? They don't open the top of the skull.
No, the neurosurgeons utilize a transsphenoidal endoscopic approach.
Meaning they go in through the nose.
Precisely. They navigate specialized endoscopes through the nasal cavity, open up the sphenoid sinus, and access the floor of the sella turcica from beneath.
Wow.
They drill through that incredibly thin bone, open the duramater, and just curette the tumor out, completely bypassing the brain tissue entirely.
And that is just a masterclass in anatomical precision.
It's a very elegant, minimally invasive procedure for such a delicate area.
Incredible. So what does this all mean for you listening? It means paying attention to subtle signals. The endocrine system is this incredibly tight, highly reactive web.
It really is.
If you or someone you know is dealing with inexplicable changes, like a mysterious drop in testosterone, secondary infertility, irregular cycles, or even weird subtle visual changes, Don't just write it off as stress.
Definitely not.
Your body's master control room might just have a jammed dead man's switch. And thankfully, modern medicine usually just needs a specialized pill to fix it.
It is a profound reminder to always seek the underlying mechanism. And, I want to leave you with a final cutting-edge thought based on the latest research in our sources.
Oh, let's hear it.
So we established that high prolactin causes infertility by shutting down the pulsatile release of GnRH from the hypothalamus.
Right, the prolactin blockade.
But researchers recently conducted trials administering a neuropeptide called kisspeptin-10 to women with hyperprolactinemia.
Kisspeptin-10. Wait, if the prolactin blockade is happening higher up in the chain, how does kisspeptin help?
Because kisspeptin operates downstream of the blockade.
Ooh.
The research showed that kisspeptin essentially hot wires the reproductive engine directly. It binds to receptors on the GnRH neurons, forcing them to fire and release luteinizing hormone, completely ignoring the prolactin-induced blackout higher up in the brain.
That is wild. So instead of just fighting the tumor with dopamine or trying to artificially lower the prolactin, we could theoretically bypass the structural problem entirely.
Exactly. Just artificially jumpstart the fertility system with kisspeptin-10.
That is amazing.
It really demonstrates that as we map these exact neural pathways, we can find pharmacological backdoors to restore physiological function. It opens up an entirely new frontier for fertility treatment.
Something totally fascinating to ponder until our next deep dive. Keep exploring, and we'll catch you next time.